Welcome back to the deep dive. Today, we are doing something a little different. We are taking a tour of a place that most of us treat with this strange mix of familiarity and honestly absolute mystery.
hmm
We are going into what you might call the engine room of female biology.
That's a great way to put it.
We're talking about the uterus, the vagina, and the ovaries, the full pelvic setup.
It really is the engine room, isn't it?
Yeah.
That is such a perfect metaphor. I mean, it powers so much, but it's all hidden away, sort of below deck.
Right.
And you're so right about the mystery. There is this massive hesitation to really engage with this anatomy.
Yeah, why is that?
I think these topics just get locked behind closed doors, or they get labeled as TMI, too much information.
Or worse, people suffer in silence. They just internalize the pain or the dysfunction. They start thinking, oh, leaking a little bit when I laugh is just part of being a woman, or this pelvic pain is just the price of getting older.
Which is such a dangerous assumption and, frankly, a bit of a tragedy.
It is, because as we went through this huge stack of clinical texts on uterine, vaginal, and ovarian pathologies, it became so obvious that this isn't just about reproduction.
Not at all.
We tend to think of these organs only in the context of, having babies. But the health of this specific region, it dictates your physical comfort, how you go to the bathroom, your sexual function, your hormonal balance, and, let's be honest, your self-esteem.
Absolutely. It touches every single part of your day-to-day life. So our mission for this deep dive is to unpack the structural and functional alterations that we found in these texts.
Yeah.
We want to move the dial from that vague, anxious feeling of something just feels wrong down there to actually understanding the mechanics of why it's happening.
We're going to look at this through two pretty distinct lenses, a mechanical lens and a metabolic one. We're talking about gravity finally winning the war against your ligaments, and we're also talking about these metabolic storms brewing inside the ovaries.
And we aren't holding back on the details. I mean, the source material is incredibly rich. We have stuff here covering mechanical failures, like when things literally fall out of place.
Which is terrifying.
It is. To bad connections, these things called fistulas.
Mm-hmm.
Even strange growths like, teratomas that can contain teeth and hair.
We have to get into that.
And, of course, the really serious stuff like malignant diseases.
So let's start with the physics problem, the mechanical failure. We're going to open with section 1. Pelvic organ prolapse, or the acronym you'll see everywhere in the literature, POP.
POP. Yeah, it sounds almost cheerful, like a pop of color.
It does. It sounds harmless.
But for the millions of people experiencing it, it is anything but. To really understand this condition, you have to first visualize the architecture of the pelvis. You need to picture something called the pelvic floor.
When I hear floor, I always picture something solid, like the floor of a house. But that's not quite right, is it?
No, it's actually much more dynamic than that.
Yeah.
I think a better way to picture it is as a complex hammock.
A hammock.
A hammock made of muscles, ligaments, and this stuff called fascia. It's just connective tissue. This hammock is strung between your tailbone at the back and your pubic bone at the front.
And its job is just to hold everything up.
Its primary job is to act as a shelf. It holds up the pelvic organs against the constant downward pull of gravity. It's cradling the uterus, the bladder, and the rectum.
A hammock is a great visual because it implies flexibility. But unlike a hammock in your backyard that maybe holds a person for an hour on a Sunday,
Right.
this hammock is bearing a constant dynamic load, 204/7. And the source material suggests that for a huge number of people, the hammock it starts to fray.
Precisely. That's the perfect word for it.
Oh.
It is a structural failure. Over time, or sometimes due to a specific trauma, those support structures, the muscles and the ligaments, they weaken, or they stretch, or they can even tear.
And once that support is gone,
When that support is gone, gravity takes the advantage. I mean, it's relentless. The organs don't have that firm shelf to sit on anymore. So they follow the path of least resistance. They begin to descend. They bulge downward into the vaginal canal.
the descriptions in the case studies we read were so visceral. Patients usually don't come in saying, my cardinal ligaments are feeling a bit loose today.
No, of course not.
They describe a feeling. They talk about vaginal pressure or a heaviness that gets worse as the day goes on. Or, and this is quite distressing, the sensation that something is literally falling out.
That is the classic bulge symptom. It's the hallmark of prolapse. It can feel like you're sitting on a small ball or an egg, but it's nuanced. Depending on what organ is doing the falling, the symptoms and the treatment can be very different. It's not always the uterus leading the charge.
Okay, so let's break that down. Let's break down the who in this falling scenario. First up, you have uterine prolapse. This seems the most straightforward to visualize, I guess.
It is. In this case, the uterus itself drops down the vaginal canal. It exists on a spectrum, or stages of severity.
So it's not all or nothing.
Not at all. It can be mild, where the cervix just dips a little bit lower than it should. Maybe you can feel it if you insert a finger, but it's not visible from the outside.
Okay.
Or, in the most severe cases, and the clinical texts refer to this as procedentia, the uterus can protrude completely outside the vaginal opening.
That sounds incredibly traumatic, both physically and psychologically. To look down and see an organ outside your own body.
It is profound. I
Okay.
mean, the impact on a person's life is immense. And you have to think about the secondary problems. The friction of that delicate tissue rubbing against underwear or skin can cause ulcerations and bleeding. It's a major, major quality of life issue.
But the uterus isn't the only player here. The bladder can also get involved. This is what the texts call a cystocele.
Cystocele, yeah.
And this is an anterior wall prolapse, right? So the front wall.
Correct. So you have to think about the anatomy. The bladder sits right in front of the vagina. There's a wall of tissue separating them. If that wall weakens and thins out, the bladder pushes against it and bulges into the vagina.
So structurally, that's a bulge, but what does that do functionally?
Functionally,
Mm.
that is a plumbing disaster.
Right. I assume this is where all the urinary symptoms come into play.
Exactly. It's like kinking a garden hose. You get this reservoir effect. First, you might have urinary frequency because the bladder is constantly irritated by being out of place.
Mm-hmm.
You might have stress incontinence, where you leak urine when you cough or sneeze or jump because the support structure for the urethra is gone. But you also get this really frustrating phenomenon called incomplete emptying.
Explain that one. What does that mean?
Well, because the bladder is sagged out of its normal position, it creates a little pouch, a pocket that sits lower than the urethra. So you go to the bathroom, you think you're done, you stand up. But a pool of urine remains trapped in that pouch.
And that stagnant pool of urine sounds like a perfect breeding ground for bacteria.
It is. Recurrent urinary tract infections, or UTIs, are a classic sign of a significant cystocele. Now, if we flip to the backside, the posterior wall, we have the rectocele.
Okay, so this is where the rectum pushes into the vagina.
Yes, same concept, different organ. The wall between the rectum and vagina thins out and weakens. And just like with the bladder, this causes mechanical issues, but this time for bowel movements.
So constipation.
People with a rectocele often struggle with constipation, yes. But it's not the kind of constipation you get from, not eating enough fiber or drinking enough water. It's a mechanical problem.
How so? What's the mechanics of it?
Well, when they bear down to try and push, the force gets misdirected. Instead of pushing the stool down and out of the anal canal, the pressure pushes it forward into the bulk, into that pocket that's herniating into the vagina. The stool literally gets trapped in a cul-de-sac.
That sounds incredibly frustrating and just deeply uncomfortable.
It is. Many patients, and this is something people don't talk about, actually have to use a technique called splinting.
Splinting.
They have to insert a finger into the vagina to physically push the rectum back into its proper place just so they can have a bowel movement.
Wow. That is a level of daily management that I think most people have no idea is happening.
It's a hidden struggle for so many.
Okay, so we have the what is falling. Now we need to talk about the why. Because looking at all the risk factors in the data, there is one massive glaring contributor here.
Childbirth, no question.
The statistics are just staggering. The text we reviewed states that approximately 78% of all pelvic organ prolapse cases are directly related to pregnancy and childbirth.
It is the single biggest driver. And the data is very clear that it's a dose-dependent risk.
Meaning, the more you have, the worse it gets.
Exactly. Just one vaginal birth increases your risk of developing prolapse by 4 times compared to a nulliparous woman. That's someone who hasn't given birth.
4 times. Just from one. That's huge.
4 times. If you have 2 vaginal births, that risk jumps to 8 times.
That is exponential. It's a massive multiplier.
It really is. And you have to understand the sheer physics of birth to get why. The pelvic floor has to distend enormously to allow the fetal head to pass through. We are talking about muscles stretching to 3 times their normal resting length.
I can't even imagine that.
That incredible stretch can damage the nerves, it can tear the fascia, and in some cases it can literally detach the main pelvic floor muscles, the levator ani muscles, from the pelvic bone. It's like overstretching a rubber band. Sometimes it just doesn't snap back to its original tension.
And the size of the baby matters too, right? That was in the text.
A huge factor. The clinical term is macrosomia large infants, And that puts significantly more mechanical stress on all of those tissues during delivery.
But it's not just childbirth, right? Because we see this showing up in people decades after they've had kids. It's not like you have the baby and then the next day your uterus falls out.
That's the tipping point factor. That's a great way to think about it. Childbirth might do the initial structural damage, maybe a small tear or a stretch that is completely asymptomatic for years, for decades even. But then menopause hits.
Ah, the hormonal shift. The second whammy.
The second whammy. Estrogen is like the glue for our connective tissue. It was fantastic for collagen. It keeps things plump, elastic, and resilient. When you hit menopause and that estrogen floor drops out, the connective tissue thins out. It becomes more brittle.
So the old injury comes back to haunt you.
Exactly. The damage from 30 years ago suddenly reveals itself because the tissue can no longer compensate for the weakness.
And then you layer on lifestyle. The text mentions mechanical stress as a whole separate category of risk.
This is basic physics. It all comes down to intra-abdominal pressure. I want you to think of your abdomen like a balloon. If you squeeze the top of the balloon, the pressure has to go somewhere.
And it goes down.
It goes down right onto the pelvic floor.
So what kinds of things cause that squeeze?
Chronic coughing is a big one. If you're a smoker and you have that chronic hacking cough every day, you are literally hammering your pelvic floor multiple times a day with these high-pressure shock waves.
Right.
Chronic constipation where you are straining on the toilet every single day. Same thing. It's a pressure event.
And weight has to be a factor.
Obesity is a huge one because it puts a constant, relentless load on that hammock. Just simple mass. Gravity is pulling that extra weight down onto the pelvic structures day in and day out. Heavy lifting too, whether it's for a job or, intense weightlifting without proper core engagement and breathing can also contribute. It all adds up to this cumulative failure over time.
So if I'm listening to this and I'm recognizing some of these symptoms in myself, or maybe I want to prevent them from ever happening, what's the play? Is surgery the inevitable destination here? Do we just have to accept that the hammock is broken and that's that?
No, definitely not. That's a really common misconception. We almost always start with conservative measures. And the first line of defense is something that everyone thinks they know, but almost everyone does wrong. Kegels.
The source material was very, very specific about this. It's not just squeeze every now and then while you're at a red light.
No, that's useless. Sporadic squeezing does almost nothing. It has to be a protocol, almost like you're lifting weights at the gym to build your biceps. You're training a muscle.
So what's the protocol?
The text specifies a regimen. First, you have to identify the correct pelvic floor muscles, which is the muscle group you use to stop the flow of urine midstream. Once you know what that feels like, you tighten them and you hold for 3 seconds.
3 seconds. Okay.
Then, and this is the part people always miss, you must relax them completely for 3 seconds.
Why is the relaxed part so important? I would think keeping it tight all the time would be better.
No, because a tight hypertonic muscle is just as dysfunctional as a loose one. It can cause pelvic pain. You need the full range of motion. You need strength, but you also need flexibility. So you contract, you hold, you relax. You repeat that sequence 10 to 15 times.
And you do that whole set. How often?
3 times a day, every day.
And the text also mentioned doing them in different positions. That was interesting.
Yes, that's critical. Standing, sitting, and lying down. Think about it. Gravity affects your organs differently in all of those positions. You need those muscles to be functional and strong in all the positions you live your life in. It's essentially physical therapy for your insides that you do yourself.
Speaking of which, dedicated pelvic floor PT is listed as a major intervention.
It is incredibly effective. In many countries, like France for example, pelvic floor physical therapy is standard, routine care after every single birth.
It should be here.
It really should. A specialist can use tools like biofeedback to show you on a screen exactly which muscles you're using to make sure you're not just squeezing your glutes or your abs. They work on core stabilization, breathing mechanics. It can significantly reduce prolapse severity without anyone ever picking up a scalpel.
And then there are pessaries. I feel like pessaries are this kind of ancient technology that's still around simply because it works so well.
That's a perfect description. It is effectively a structural support device. Think of it like an orthotic for your shoe, but for the vagina.
Okay.
It's a removable device, usually made of medical-grade silicone, that you insert into the vagina to physically shore up the walls and hold the organs back in their proper place.
What do they look like? I'm picturing something complicated.
There are over 20 different types, which is amazing. Some look like rings, some look like donuts, some look like cubes or dishes.
Yeah.
It really depends on your specific anatomy and which organ is falling. A trained provider fits you for one.
And it seems like a great option for someone who wants to manage the symptoms but maybe isn't ready for or can't have surgery.
It is fantastic for that. You can wear it all day, take it out at night to clean it, or some types can be left in for longer periods. It provides immediate relief.
But if the pessary fails or if the prolapse is just too severe, surgery is on the table.
Surgery is the definitive fix. If those conservative measures don't provide enough relief, yes. Surgeons can go in and use the patient's own tissue to rebuild the support structures, or sometimes they use a synthetic mesh to reinforce the wall. But it's major surgery, which is why we exhaust all the other options first.
Okay, let's pivot. Let's move from things sagging and falling to things connecting where they absolutely shouldn't. We are moving into section 2, genital fistulas. The definition in the text is pretty chilling. Abnormal passageways.
A fistula is, quite literally, a tragedy of anatomy. It's a hole. It's a tunnel that forms between two organs that should be completely separate compartments. In this context, we are usually talking about a breach in the wall between the genital tracts of the vagina and the urinary or the intestinal tract.
The types listed here are vesicovaginal and rectovaginal. Let's decode those for the listener because the Latin actually tells you exactly what is happening here.
It does. So vesicovaginal is a connection between the bladder vesico and the vagina. So normally, urine stays in the bladder until your brain tells the sphincter to open and you urinate through the urethra. But here, the wall between the two breaks down.
And the urine just leaks out.
Urine follows gravity and the path of least resistance. It bypasses the urethra entirely and leaks continuously into the vagina and out of the body.
Continuous leakage. Not just with a cough, but all the time. That sounds like an absolute nightmare for quality of life.
It is uncontrolled. It's not, oops, I sneezed. It is a constant, unremitting trickle or flow of urine.
And rectovaginal. Same principle.
Same principle, different system. That's a connection between the rectum and the vagina. So now you have the passage of feces or gas coming out through the vaginal canal instead of the anus.
The impact of this, the text uses the phrase profound effect on body image and social life. That feels like a massive understatement.
It's devastating. I mean, just imagine the logistics of hygiene management. The odor is very difficult to mask. The constant dampness from urine or feces leads to skin excoriation and breakdown, which is physically painful. But the psychological toll is, I would argue, even worse.
I can imagine people just completely withdraw. They become hermits.
They do. They isolate themselves. They stop dating. They stop going to work. They stop attending family gatherings because of the deep shame and the constant fear of an accident. In some cultures, this leads to total social ostracization. Women are abandoned by their husbands and families.
It's heartbreaking. So how does this happen? Is this just bad luck? A random mutation in the tissue?
No, it's almost always trauma-based.
Yeah.
If we look at this globally, particularly in low-resource settings in parts of Africa and Asia, the most common cause by far is prolonged obstructed labor.
So this is back to childbirth again.
Yes, but in a particularly horrific way. If a woman is in labor for days on end without access to a C-section, the baby's head gets stuck and presses unrelentingly against the pelvic bone. It pinches the soft tissue of the vagina and the bladder or rectum in between.
And it cuts off the blood supply.
It completely cuts off the blood supply to that tissue. The tissue dies, it becomes necrotic, and a few days later, it just sloughs away, leaving a hole behind.
That is just awful. But the text also mentions causes in high-resource settings, like here in the U.S. or in Europe. It's not just an obstetric issue there.
Correct. Here, it's rarely caused by labor. It's more often iatrogenic, which is a fancy way of saying caused by medical treatment.
Okay.
It could be a complication of pelvic surgery, like a hysterectomy where the bladder is accidentally nicked or stitched, or it can be a delayed result of radiation therapy for pelvic cancers. Radiation is great at killing cancer cells, but it also damages the blood supply to healthy tissue, and a fistula can form months or even years later as that tissue breaks down.
Or inflammatory diseases, right?
Yes. Conditions like Crohn's disease or diverticulitis. The inflammation can be so severe that it literally eats a tunnel through the tissue walls to connect the bowel to the vagina.
So if a patient suspects a leak, how do they confirm it? What's the diagnostic process? It sounds like it could be hard to pinpoint.
It involves some clever detective work. The simplest test for a suspected bladder fistula is a dye test. It's quite ingenious. They fill the bladder with a sterile blue dye via a catheter. Then they place a clean tampon in the vagina.
And they wait.
They ask the patient to walk around, maybe cough or jump up and down for a bit. Then they take the tampon out.
And if the tampon turns blue,
Then, with certainty, that the fluid is coming from the bladder. It's not uterine discharge or anything else.
Yeah.
You've confirmed a vesicovaginal fistula.
And if it's more complex or they need to know the exact location?
Then we use technology. A cystoscopy, where they put a tiny camera into the bladder to literally look for the hole. Or advanced imaging, like CT urograms, to create a 3D map of the entire urinary tract. You have to know exactly where the hole is and how big it is to plan the repair.
And fixing it is purely surgical. There's no medication for this.
Almost always surgical, yes. For very mild, tiny fistulas, sometimes they might heal on their own with bowel rest for the gut or by keeping a catheter in the bladder for a few weeks to keep it constantly empty. That gives the tissue a chance to close. But usually, the edges of the hole heal open. So you need a surgeon to go in, carefully cut away the scar tissue, and then sew the layers, the bladder wall and the vaginal wall, back together separately.
Okay, let's travel deeper inside now to the ovaries. Section 3. The ovaries seem to be these busy little factories, constantly changing, but sometimes they produce things they shouldn't. We're talking about cysts and tumors.
The ovary is a really unique organ. It's one of the only organs in the body that is designed to rupture and then heal itself every single month as part of ovulation. It's incredibly dynamic. It grows follicles, it releases eggs, and because of that constant cellular turnover, it is prone to developing these fluid-filled sacs, which we call cysts.
And the important takeaway here seems to be that the vast majority of these are benign.
Absolutely. The text mentions that anywhere from 8 to 35% of premenopausal females have these at any given time, most without even knowing it. So if you get an ultrasound report that says ovarian cyst, the first step is not to panic.
Right. Don't panic immediately.
Correct. Most are what we call functional cysts. They are not a disease. They're just a little hiccup in the normal process of ovulation.
Like follicular cysts. That was the first one listed.
Exactly. So every month, an ovary prepares an egg inside a little fluid-filled sac called a follicle. Usually around mid-cycle, the follicle bursts and releases the egg. But sometimes, for whatever reason, it doesn't. It fails to rupture. It just keeps growing and fills with more fluid. That's a follicular cyst.
And they just go away.
Usually, yes. They are almost always asymptomatic, and they resolve on their own within a cycle or two. Your body just reabsorbs the fluid.
And what about the corpus luteum cyst?
So that one forms after the main event, after ovulation. The corpus luteum is the structure left behind after the egg pops out. It's meant to produce progesterone to support a potential pregnancy. Normally, if you aren't pregnant, it just dissolves. But sometimes the exit hole from where the egg was released seals up, and it fills with fluid or sometimes blood.
And these are also usually fine.
Again, usually self-resolving, though these can be a little bit more painful or cause some bloating because they can get a bit larger before they go away.
Okay, so those are the normal-ish ones, the functional ones. Now we have to talk about the strange growths. Because there is one in here that sounds like something out of folklore, but is 100% clinical fact. The dermoid cyst.
Ah, yes. The mature cystic teratoma. They are absolutely fascinating and, I will admit, a little unsettling to think about.
Unsettling is the word. The text says they can contain fully formed tissues like bone, hair, and teeth. I have to stop you there. Teeth inside an ovary.
Yes. Fully formed teeth, clumps of hair, sebum, which is like a greasy skin oil, sometimes thyroid tissue, cartilage, or even neural tissue.
How is that even possible? Where does that come from?
So these are what we call germ cell tumors. They form from the primordial cells, the cells that create eggs. These cells are pluripotent, meaning they have the potential to become any type of tissue in the body. That's their job in an embryo, to differentiate into everything.
Right.
But here, a cell goes rogue. It gets confused. It starts building a molar or a patch of hair or a bit of bone inside the ovary without the rest of the blueprint for a body.
That is just wild, and it says they form from fetal life.
They're thought to be present from birth, usually. They just grow very, very slowly over a person's lifetime. You could be walking around with one right now, a tiny one, and have no idea.
And are they cancerous?
The mature ones are overwhelmingly benign, not cancer, but they can get heavy. And because they are weighted unevenly, bone is heavy, fat is light, they pose a significant mechanical risk. Ovarian torsion.
Torsion. That sounds like a physics term. It sounds painful.
It's a true surgical emergency. Because the cyst makes the ovary top-heavy and unstable, the entire ovary can flip over. It twists on its own blood supply, on the ligaments that hold it in place, like twisting the stem of an apple. It completely cuts off the blood flow.
And what would that feel like?
Sudden, Sharp, excruciating one-sided pelvic pain, often with nausea and vomiting because the pain is so intense. This isn't take an ibuprofen and lie down pain. This is call an ambulance right now pain.
And if you don't fix it?
If you don't get to surgery and untwist it very quickly, the ovary can die from lack of oxygen, from leukemia. It becomes necrotic and has to be removed.
So if you have a known dermoid cyst, especially a large one, they might recommend removing it proactively just to avoid that risk.
Often, yes, especially if it's over 10 centimeters or if it's causing intermittent pain, which might mean it's partially twisting and untwisting. We don't want to risk the full torsion event.
Okay, let's move from the structural weirdness of cysts to a condition that affects the whole system. Section 4, polycystic ovary syndrome, or PCOS.
This is a big one, a really big one. It affects somewhere between 6 to 10% of reproductive age females. But the name polycystic ovary syndrome is actually a bit misleading.
How so?
It makes it sound like it's purely a gynecological structural problem, like, oh, I have a bunch of cysts on my ovaries. But the source material is adamant that this is, first and foremost, a metabolic disorder.
Right, it calls it a metabolic storm. That feels like a rebrand is desperately needed for this condition.
It really is a systemic issue. It's a complex interplay of hormones and insulin that affects the whole body. The clinical picture usually involves 3 main pillars. This is known as the Rotterdam criteria, and you typically need 2 of the 3 for a diagnosis. First is ovulatory dysfunction.
Which means missed or irregular periods, right?
Right. Anovulation or oligoovulation. You aren't releasing an egg regularly, so your periods are very irregular, infrequent. The term is oligomenorrhea, or they might be completely absent, which is amenorrhea.
Okay, that's pillar 1. What's number 2?
Pillar 2 is androgen excess, so signs of high testosterone.
And what does that look like on a person?
This manifests physically in ways that can be really tough for self-esteem. We see hirsutism, which is excess, coarse, dark hair growth in a male pattern, so on the face, the chin, the chest, the abdomen. We see severe cystic acne, particularly along the jawline, that doesn't respond to normal creams. And we can see androgenic alopecia, which is male pattern hair thinning on the scalp.
And the third element is the ovaries themselves.
Yes, the polycystic part of the name. On an ultrasound, the ovaries often look enlarged.
Yeah.
They have this classic string of pearls appearance around the edge.
Okay. But here is the kicker you mentioned. The text says these aren't cysts in the way we just discussed follicular cysts.
That's right. They are not cysts. They are actually immature follicles. They are follicles that started to grow, trying to prepare an egg for release, but the hormonal signal got jammed halfway through the process. So they just stalled out. You get this buildup of dozens of tiny stalled follicles around the periphery of the ovary.
But why did you call it a metabolic storm? What's going on underneath the surface that connects all these things?
This is the crucial part for long-term health. PCOS is strongly linked to insulin resistance.
Like in diabetes.
Exactly. The body's cells don't respond to insulin effectively, so the pancreas has to pump out more and more insulin to try and get the job done to get glucose into the cells. You end up with high circulating levels of insulin in your blood.
And what does all that extra insulin do to the ovaries?
High insulin levels have a direct stimulating effect on the ovaries. It tells them to produce more testosterone. It's a vicious cycle. The insulin resistance causes high insulin. The high insulin drives high androgens, and the high androgens disrupt ovulation and cause the physical symptoms.
And the comorbidities listed here are really serious. It's not just about periods and acne. It says type 2 diabetes, sleep apnea, fatty liver disease, depression.
And major cardiovascular risks. This isn't just a fertility issue. This is about your heart health 20, 30 years down the line. Women with PCOS have a significantly higher risk of developing metabolic syndrome, high cholesterol, and high blood pressure. It's a bright red warning light on the dashboard for your overall metabolic health.
So how do we treat it? It's not just a pill, is it? The text lists lifestyle as the absolute first line of defense.
Because of that core insulin link, diet and exercise are paramount. But it's not about just lose weight or shaming the patient. That's not helpful. It's about interventions that improve insulin sensitivity.
What does that look like?
It could be a lower glycemic diet, regular exercise, both cardio and strength training. We know that losing even 5 to 10% of your body weight if you are overweight can significantly lower insulin levels and in many cases restart spontaneous ovulation.
And medications. I see metformin on the list, which, as you said, I usually associate with diabetes.
We borrow it directly from the diabetes world for this exact reason. Metformin is an insulin sensitizing drug. It helps the body use insulin more effectively. It lowers blood glucose, and it reduces that insulin drive that's messing up the ovaries. It can help regulate cycles and can aid in weight management.
But the text has a big warning about side effects for metformin.
Oh yeah, the GI side effects are notorious. Diarrhea, nausea, cramping. The pro tip here is to always take it with meals to buffer that and to start on a low dose and increase it slowly. Usually, your body adjusts over a few weeks, but you have to warn patients about it or they will absolutely quit taking it after 3 days.
And for managing the hormonal side, the androgens?
For that, combined oral contraceptives, the birth control pill, are often the gold standard, assuming pregnancy isn't the immediate goal.
And how do they help?
They work in 2 ways. First, they provide a regular, predictable withdrawal bleed, which protects the uterine lining from overgrowing due to the lack of regular periods. And second, and this is key, the estrogen in the pill increases a protein in the blood that acts like a sponge for testosterone. It binds up that excess free-floating androgen, effectively cleaning it out of the system. That's what helps clear up the acne and the hirsutism over time.
Okay, let's go back to the uterus itself. We've talked about it falling out, but things can also grow in it. And we need to distinguish between polyps and fibroids. I feel like these two terms get used interchangeably by people all the time, but they are completely different things.
They are very different tissues. You have to think of the uterus and its layers. You have the inner lining, the endometrium, which is the tissue that builds up and sheds every month during your period. Then you have the thick muscular wall, the myometrium, which is what powerfully contracts during labor.
So a polyp is an issue with the lining.
Exactly. A polyp is an overgrowth of the lining. It's soft, it's fleshy, it's glandular tissue. The best analogy is to imagine a skin tag, but growing on the inside of the uterine cavity.
Are they dangerous?
They are usually benign, though they do carry a very small risk of containing cancerous or precancerous cells, especially in postmenopausal women. And because they are part of that fragile vascular lining, they often cause symptoms like spotting or bleeding between periods.
Okay, so that's a polyp. Now, a fibroid.
A fibroid, or its medical name, leiomyoma, is a tumor of the muscle. It's a completely different tissue. It's firm, it's dense. You have a hard, whirled ball of smooth muscle, almost like a gristly rubber ball or a stone.
And they can get big?
They can get huge. We see fibroids that are the size of a marble, but also the size of a grapefruit, a cantaloupe, or in some extreme cases, a watermelon, filling the entire abdomen.
The demographics on fibroids are startling. The text was very clear that Black clients are 2 to 3 times more likely to develop them.
Yes, and this is a significant health equity issue that we need to talk more about. Not only are fibroids more common in Black women, but they often develop at younger ages, they grow larger, and they cause more severe symptoms.
Do we know why that is?
We don't fully understand the why, but the text lists several potential contributors. There are genetic predispositions, but also higher rates of vitamin D deficiency, which is a known risk factor, higher rates of obesity and hypertension in the community, and there's an emerging field looking at exposure to endocrine-disrupting chemicals, potentially in certain hair products or other environmental factors. It's a really active and important area of research.
What does a fibroid feel like? Or do you even feel it at all?
Many are completely asymptomatic. You might not even know you have one until you get an ultrasound for something else entirely. But depending on their size and, crucially, their location, they can cause a whole host of problems.
Like bleeding.
The number one symptom is heavy, prolonged menstrual bleeding. The clinical term is abnormal uterine bleeding, or AUB. I'm talking about bleeding that soaks a pad or tampon every hour, passing clots the size of quarters or larger. This often leads to significant iron deficiency anemia, which causes fatigue, dizziness, and shortness of breath.
And they just take up space, right? They're bulky.
Exactly. They cause bulk symptoms. If they grow on the front of the uterus, they press on the bladder, causing you to have to urinate constantly. If they grow on the back, they press on the rectum, causing constipation and back pain. They can cause a visibly distended abdomen, pelvic pressure, and even dyspareunia, which is pain during sex.
The treatment spectrum listed here is really interesting because it's not just cut it out or get a hysterectomy.
No, absolutely not. We have a whole ladder of interventions now. For mild symptoms, you can manage pain with NSAIDs like ibuprofen. You can use hormonal therapies like certain IUDs or pills to try and shrink them, or at least control the heavy bleeding.
And then there are the more high-tech procedures, like uterine artery embolization or UAE.
This is a fascinating engineering solution to a biological problem.
It's basically chopping off the blood supply to the fibroid.
That's exactly what it is. An interventional radiologist threads a tiny catheter through an artery in your wrist or groin all the way to the arteries that feed the uterus. Then they inject these microscopic particles, like tiny grains of sand. These particles flow into and block the blood vessels that are specifically supplying the fibroid.
And the fibroid just dies.
It starves of oxygen and nutrients. It dies, and then it shrinks significantly over the next few months. It's a great, minimally invasive option that preserves the uterus.
That's incredible. And there's sound wave technology, too.
MRI-guided focused ultrasound.
Yeah.
It's even less invasive. It uses high-intensity sound waves focused with MRI precision to literally cook and destroy the fibroid tissue from outside the body without making a single incision. It's like something out of science fiction.
But of course, surgery remains a pillar for some cases.
Yes. For women who want to preserve their fertility, a myomectomy is an option. That's a surgery to remove just the fibroids, like scooping the seeds out of a piece of fruit and then reconstructing the uterus. Or for women who are done with childbearing and want a definitive cure because fibroids can grow back, hysterectomy, the removal of the uterus entirely, is the ultimate solution.
Okay, we have to move to the most serious section now. Section 6, malignant neoplasms. The cancers. This is heavy stuff, but the text emphasizes over and over that knowing the signs is the difference between an early stage, curable disease and a late stage, much more difficult one.
Absolutely. This is where awareness saves lives. Gynecological cancers are named by where they start, their primary tumor site. Let's start with the most common one in developed countries, endometrial cancer.
So this is cancer of the uterine lining, the endometrium. What is the #1 signal for this?
The biggest red flag here, and if you take nothing else away from this entire section, please remember this, is abnormal uterine bleeding, especially any bleeding at all after menopause.
So just to be crystal clear, if you have stopped having periods for a full year, you are technically postmenopausal. If you see blood after that, even a little bit.
You go to the doctor immediately, that day. It is never, ever normal. It might turn out to be something benign like a polyp or tissue atrophy from lack of estrogen, but you have to rule out cancer first.
What drives this type of cancer?
The driver is often unopposed estrogen. Having high estrogen levels without enough progesterone to balance it out and protect the lining. This is why obesity is a major risk factor, because fat tissue biologically converts other hormones into a form of estrogen. Also, women taking the drug tamoxifen for breast cancer need to be watched closely for this, as it can stimulate the uterine lining.
Next on the list is ovarian cancer. This is the one that really scares people because it's often called the silent killer.
It has a high mortality rate, primarily because we lack a good, reliable screening test. And the early symptoms are incredibly subtle and vague. They mimic everyday, minor issues.
What are
The text lists things like persistent abdominal bloating that doesn't go away, early satiety, which means getting full really fast after eating just a few bites of a meal, and urinary urgency or frequency.
That sounds like indigestion. Or just having a bloated day. Or a UTI.
It does. And that's the danger. People ignore it for months. They think it's IBS. They change their diet. They take probiotics. The key is, if those symptoms are persistent, happening almost every day for several weeks, and they are new for you, they need to be checked out.
Is there any kind of test they can do?
There's a blood test for a tumor marker called CA-125. It's elevated in about 80% of advanced ovarian cancers, but, and this is a big clinical nuance, it can also be raised by many benign things, like fibroids, endometriosis, liver disease, or even pregnancy.
So it's not a good screening tool.
Not for the general population, no. You'd get way too many false alarms and unnecessary surgeries. But it's very useful for monitoring treatment, or if a doctor already has a high suspicion based on an ultrasound or a CT scan.
And genetics play a big role here.
A huge role. The BRCA1 and BRCA2 gene mutations, which are also linked to breast cancer, significantly increase the lifetime risk of ovarian cancer. If you have a strong family history of breast and ovarian cancer, genetic counseling and testing are absolutely vital.
Okay, moving to cervical cancer. This one is really unique because we know the cause for almost every single case.
Yes. 99.7% of all cervical cancer cases are linked to a persistent infection with HPV, the human papillomavirus.
That is a staggering, unbelievable percentage. It's essentially a viral disease that becomes a cancer.
It completely changes how we view the disease. It's not a random cellular mutation. It's caused by a persistent infection with specific high-risk strains of HPV. So the risk factors all align with exposure to the virus, early onset of sexual activity, having multiple partners, but also, interestingly, smoking.
How does smoking affect cervical cancer risk?
Smoking suppresses the immune system locally in the cervix, making it much harder for your body to clear the HPV virus on its own. So the virus sticks around longer, giving it more time to cause cellular changes.
But because we know the cause and it's a slow process, we have excellent screening.
The best. The PAP test, which looks for abnormal cells, and direct HPV testing. We can catch the cells when they are just starting to change. We call this dysplasia, or CIN, long before they ever become an invasive cancer. It is a highly preventable disease with regular screening and, of course, the HPV vaccine.
And finally, a quick mention of vulvar and vaginal cancers. These are much rarer.
Much, much rarer. Vulvar cancer is cancer of the external genitals. It's often linked to HPV and smoking as well, but also to a chronic inflammatory skin condition called lichen sclerosus. It usually manifests as a persistent itch, a burning sensation, or a visible sore or lesion on the vulva. Vaginal cancer is exceptionally rare and is usually a metastasis, meaning a cancer that's spread there from the cervix or the endometrium.
Before we wrap up, I want to touch on the final section from our reading, Section 7, which is about the nursing and care perspective. Because we've talked a lot about mechanics, chemistry, and oncology, but there is a human being at the center of all of this.
Yes, and these conditions, prolapse, fistulas, PCOS, cancer, they strike at the very core of identity for many people. They affect sexual function, body image, fertility, and the ability to control the most basic bodily functions like urination and defecation.
The text says that management isn't just about the surgery or the medications, it's about the psychological support.
Absolutely.
Mm.
A nurse or a good provider isn't just checking incisions or blood work. They are watching for the clinical red flags, like sudden acute pain suggesting a cyst rupture or signs of a bowel obstruction in advanced ovarian cancer.
Meh.
But they're also holding space for the enormous emotional impact.
Right.
They're the ones helping a patient navigate the profound shame of a fistula or the deep anxiety of a cancer diagnosis. They're educating about hygiene, body mechanics, self-care, and connecting people to support resources. That part of the care is just as important as the scalpel or the prescription.
So what does this all mean? We've covered a massive amount of ground today, from physics to hormones to oncology.
We have. And if you try to synthesize all of it, what you see is that the pelvic region is this incredibly complex interplay of structure. Those muscles and ligaments and the hammock we started with in chemistry, the hormones and the insulin, they're driving the ovaries and the uterus.
It seems like there's a very delicate balance. One thing goes wrong and it has a cascade effect.
It is remarkably robust. I mean, think about what the body endures during childbirth, stretching to what seem like impossible limits, and yet it's also remarkably sensitive to subtle shifts.
And the common thread, the big takeaway for anyone listening, seems to be paying attention.
Exactly. It's about moving from that vague sense of something feels wrong to actually taking action, whether it's that sensation of heaviness that could be prolapse or the persistent bloating in ovarian issues or any irregular bleeding, especially after menopause. For uterine issues, listen to the engine room. Don't let the stigma or the embarrassment silence the symptoms.
Here's a final provocative thought to leave you with, something that really struck me from the readings. We talked about how the female reproductive system is robust enough to expand for childbirth, an event that increases your prolapse risk by 400%. Yet it's simultaneously so sensitive that a simple vitamin D deficiency or a single common viral infection like HPV can alter your cellular biology forever.
It really requires us to rethink what we consider a normal part of aging versus what actually requires and deserves intervention. Just because something is common, like mild prolapse or leaking, doesn't mean it's something you simply have to live with.
Thanks for diving in with us.
See you next time.